Now, mind you, a shoulder is a structure, a joint rather, there are a lot of structures in and around this. Now, if you could see the axillary nerve, which is in green, it is so close to think. Now, this is when you're being from the back. Okay, so when you have an anterior dislocation, obviously you can expect some stretching of the nerve. Okay, the axillary nerve, that is the nerve which is at risk for dislocations. And of course, the vessel also is very close, axillary artery or the brachial artery, and even those could be injured. Okay, so axillary nerve, how do you check? It's very difficult to check the motor component of axillary nerve, especially in a dislocated and a fractured shoulder. But what we need to fall back on is the sensory component. So as we can see, what is called the regimental badge sign. So that area over the proximal part of the arm. Okay, so the soldiers on the sleeves, they wear their badge. So that's the regimental badge sign. So on that area, you could just check for hypoesthesia. So even in a fractured and dislocated limb, the patient should be able to tell whether it looks hypoesthetic. And if that is the case, we have to start thinking that there is an axillary nerve injury and can warn the patient, also document. Now, all of these are very critical because if we do not do that, after a reduction or after a surgery, the patient can start complaining that this was done as an after effect of the treatment and not because of the injury, right? So it's always to be safe, we need to do a thorough clinical examination. Also, whenever now, as a matter of fact, in any of the fractures or any of the dislocations, we need to look into distal vascularity. That's it's by protocol we need to be doing that whether the vessels are intact or not. But if you see such an injury where the shaft is medialized, now if you look into this, the shaft has a significant medial spike on the medial side. It's a very sharp end point, and that is significantly medialized, right? Now, if you see such an injury, you have to be doubly sure whether the artery is in place or not. What may also happen is there could be a such significant intimal tear leading to a delayed thrombus. Okay, now this spike can hit the vessel and come back, leading to a delayed thrombus. So you should always keep a watch. So, in fact, there are recommendations now that if there's any doubt or for such nasty injuries where the shaft has been medialized with a big spike, always get a CT angio. Now, if you could look into this, although the artery is intact, but there is some damage caused because of the diaphysis into the axillary artery. Now, this can lead to a pseudoaneurysm over a period of time, or it could even lead to a delayed thrombus. We need to keep a watch out for. Okay, so that's two things. Always remember: look out for nerve injury, look out for artery injury. Artery injury may require a CT angio if you're suspecting. There is no harm because this particular thing is that close lying to the artery that even during reduction, whether closed or with an open method, we can damage the arteries. Okay, so even as a knowledge, we need to realize how close the artery is to the medialized shaft and need to take care when you're reducing this introp. Okay, do not put any spikes or levers that may damage the artery itself. Investigations, basically two views. Again, we may start thinking that the second view is difficult, but Welpe view or an axillary view is not that difficult whatsoever. It's very, I mean, as long as we have splintered the limb and the patient can lean backwards, we may get, yes, of course, we will not get the exact image like how it's been described, but some sort of a second, a different plane of imaging always helps because that gives us a little more information as to what the patient has, right? Because the dislocations may not be very obvious in one view. Now, mind you, again, this is very common in a posterior dislocation, which is missed. In anterior dislocation, things are much more obvious, but in posterior dislocation, it may be subtle. I mean, we'll come to those excesses a little later also, but there is a tendency for us to overlook these injuries because we may presume it to be normal. So that's why the second view, if taken, gives a higher chance of us being able to really pinpoint and tell that there is a dislocation. Then also get a CT scan. Now, CT is mandatory nowadays. Okay, for all fracture dislocations, see, we need to get a CT scan. Now, why we need to get a CT scan and when do we get a CT scan is a little different. Now, we'll learn that over a period of time through this talk. But CT is mandatory. MRI may be done in certain scenarios if you're considering soft tissue injuries along with the bone injury, like a cuff tear, like a labral tear, all those. Now, if you have reduced this dislocation and it is a little unstable, then yes, we may get done an MRI. But otherwise, as routine for a fracture dislocation, MRI is not really indicated. Okay. The question is, the patient has come to you with a fracture dislocation. Do you reduce the joint and get a CT, or do you get a CT before the reduction? Now, anywhere else in the body, for example, you have a knee, you have a hip, you have an ankle, the dictum is always reduce the joint and then get a CT, right? And that's true even for shoulder in most cases. But now, for example, a simple fracture dislocation like this, what we spoke of, that the major problem is the dislocation. You have a smaller fracture. Now, in these, we may very well reduce it, confirm the reduction, not of the joint. Now, reduction confirmation of the joint is by being patient able to move, you're able to internal rotate the shoulder, touch the opposite shoulder for an anti-dislocation. You realize without getting any investigation, the joint is reduced. But we need to know whether the GT fragment which is fractured has fallen back perfectly well to where it belonged so that it could heal. Now, for that, an X-ray might not be good enough, because many times what happens is we have a slight inversion or inversion of these fragments, a slight rotation of these fragments, and they will not heal, right? So you will require a CT scan, and only if under CT you are well assured that the fragment has fallen back, then you can continue to treat conservatively and the things go on to heal well, of course, right? So in these typical scenarios, the dictum remains that you reduce the joint and we then get a CT. But be very, very sure that what you are dealing with is a fracture of a GT and a dislocation of the entire remaining part, and the patient does not have an additional surgical neck fracture. Now, many times the fracture may be missed. Now, in this case, for example, it looks like a typical fracture dislocation where you have fractured the GT and the head is dislocated and the shaft. There is no fracture. It seems that there is no fracture between the head and the shaft. Okay. And you can see a post-reduction X-ray where the GT has not fallen back perfectly. And you are seeing some double contouring and you are starting to think what exactly the problem is. And of course, you then get a CT done. And then you realize that the patient also had a surgical neck fracture. Luckily for us, the surgical neck did not displace. So that's what can happen is, if you're having such injury and you're trying to reduce, because the patient already has also a surgical neck fracture, only the shaft may displace, right? So the head may stay dislocated in the axilla and entire shaft can get displaced. So what was an undisplaced fracture can become a completely displaced fracture, right? So we have to be very, very sure that the patient does not have a surgical neck fracture along with this, because if the patient has that and an undisplaced fracture becomes a displaced fracture, then we are risking an avascular necrosis, also a non-union, significantly higher incidence of these complications rather than the patient not having this. Okay. So be very sure about that. So this patient, luckily, all things reduced in one go. And then when you get a CT, you realize there's a surgical neck, also a GT fracture, also a head split fracture. Now, all of these makes it a much more complex fracture dislocation, not a simple fracture dislocation. So in these scenarios where you have the doubt before reduction, whether the patient has a surgical neck fracture along with the GT fracture or not, now the recommendation is get a CT before reduction, reduce it, and then of course you need to repeat the CT after reduction, because you need to see whether the things are reduced well, plus whether the GT has fallen. Right. So this is the only condition rather where you would get a CT even before you attempt a reduction. Okay. And after reduction, CT is very, very crucial, because an X-ray will almost always miss out on these injuries which are on the glenoid side. So we can have an anterior rim or even the inferior rim of glenoid fractured because of dislocation. And if we do not realize it or do not address this, then this can lead to recurrent dislocations. It will be very, very unstable shoulder, and patient is not going to do well, right? So not to miss out on this, a CT post-reduction, even if the Excel looks perfect, if the Excel looks brilliant, do not prevent yourself from getting a CT, because you need to look out for these additional injuries that are very common. The anterior glenoid rim fractures are reported as high as 20% in some series, right? So you do not want to miss out on these injuries, because that is going to definitely have a bearing on how you're going to manage this patient. So even if your reduction is perfect, this glenoid requires a treatment and some sort of a fixation / suturing of it.